Hi there, this is Aaron Filler. I'm a neurosurgeon in Santa Monica, California, and this segment is about thoracic outlet syndrome and brachial plexus entrapments, how to diagnose, how to treat. So first, I'm going to be going through some categories of thoracic outlet syndrome so you can understand the various subtypes. And this is important because there are a number of different conditions that fall under this general term. And so there's been confusion about what exam findings need to be present or the implication of the absence of a particular finding. And I hope to resolve some of that uncertainty with this overview, particularly given the fact that many neurosurgeons had relatively little training with thoracic outlet syndrome. We're going to go through the diagnostics, both the physical exam, and then I'm going to spend a lot of time on imaging because this has really transformed our understanding of the pathology and treatment options. We'll discuss normal anatomy, the types of normal image findings for the plexus, the types of findings that neurography can show that help with understanding the requirements of treatment and the underlying pathology. Then we'll go through some of the major subtypes, particularly scalene syndromes, syndromes related to rib abnormalities, and distal entrapments. We'll talk about treatments in the form of MRI-guided injections, some categories of the surgery, supraclavicular, axillary, first rib, and the kind of outcomes that one can expect, which are actually very good overall. These strategies produce generally better outcomes to a higher reliability than most spinal surgeries do for spinal diagnoses, so it's well worthwhile for the neurosurgeon to be able to know when to consider these diagnoses, how to get the exact right treatment, how to do it, and to get a great result for this category of patients. To begin with, we'll consider the classic dermatome diagram. This is a good place to start because for spinal diagnoses, this is very reliable, but for peripheral nerve, particularly brachial plexus, it can be very misleading. You may remember those complex brachial plexus diagrams and how the nerves seem to come together and divide and rejoin, and this really mixes up the dermatomes. So if you approach a brachial plexus patient with a dermatome mindset, you have a very difficult time understanding the diagnoses. And so I'm going to step through the most important reasons why dermatomes can be misleading for thoracic outlet cases. So first of all, with this diagram that comes from one of my books, I just want to go through, review a few of the basics. We have the ventral rami, C5, C6, C7, C8, and T1, and the 5 and 6 join to form the upper trunk, C7 middle trunk, C8, T1 lower trunk. And just to review, upper trunk generally is going to do with deltoid biceps, middle trunk triceps and wrist extension, lower trunk hand. This is an important point because you need to look at what happens as the plexus elements progress to form the median nerve. You start with C5 and C6. They pass through the upper trunk. The upper trunk divides into an anterior and posterior division. And look what happens. The anterior division joins the lateral cord. The lateral cord then sends out an antecedent that forms part of the median nerve. So the median nerve is getting, for instance, the C6 sensory fibers are going to go to the thumb. On the other hand, let's look at C8 and T1. They're going to form the lower trunk down below. The lower trunk is going to form its posterior division that feeds into the posterior cord, but the anterior division is going to lead into the ulnar and median nerve. So it's going to be providing C8 and T1 motor fibers to both the ulnar and median nerves. So the median, when it crosses the wrist, is going to carry sensory from C6 for the thumb, but motor for the thenar eminence coming from C8 and T1. It mixes them. And this is very important in distinguishing the diagnoses when you examine somebody with a painful or weak hand. Look at the medial cord feeding into the ulnar nerve, delivering both motor from C8T1 and sensory from C8T1. And here's the consequence of all this as you look at it. When someone has just fourth and fifth digit pain and numbness and hypothenar weakness, you can think ulnar nerve. It could be Guillaume's canal, it could be cubital tunnel being the obvious common one. And in the situation of a carpal tunnel, median nerve compression, you can expect to see first, second, and third digit pain and numbness and thenar weakness. But what happens with a thoracic outlet case is typically patients will get a fourth and fifth digit pain and numbness, there's C8T1, in the lower trunk, because it's a lower trunk impingement we're worried about here. The lower trunk's got the C8 and T1, all of it. Because of that, you'll knock out the sensory C8T1 or cause irritation, so fourth and fifth digit pain and numbness, but both the thenar and the hypothenar eminence will be affected, which is very different from an ulnar entrapment distally, wherein you get the C8 and T1 fibers affecting pain and sensory for fourth and digit, hypothenar, but you don't get the thenar eminence. So when you see fourth and fifth digit symptoms in both thenar and hypothenar weakness, you got to think lower trunk rather than carpal tunnel or cubital tunnel. And this anatomy is what's showing why. It's because in a number of types of thoracic outlet syndrome, you get a lower trunk impingement. Now, that's not the only category, because thoracic outlet is going to cover any number of things affecting the upper trunk, the middle trunk, the lower trunk, all three, the divisions, the cords. But a very common presentation essentially is a lower trunk impingement, and that's that key thing you need to think about. Fourth and fifth digit numbness, which let's think about the spinal aspects. Very rare from the spine. Why? Because, sure, C4-5, common disc herniations, foraminal impingement. C5-6, common. C6-7, common. But how often do you get C7-T1 pathology? Much less common. So when you're seeing C8 and T1 symptoms coming from somewhere proximal, again, you got to think lower trunk, thoracic outlet, because it's much less likely to be spinal in origin than when you see C5, C6, or C7 pathology. Now, we can also look at some of the first rib related or cervical rib anomaly related syndromes. And the significance of these in the larger scale of all thoracic outlet patients is minuscule. They're rare. They figure prominently in the neurosurgical mind because without MR imaging of nerves and with a lot of confusion about diagnosis and treatment, the finding of a cervical rib on an X-ray in a patient with a puzzling lower trunk syndrome would immediately snap the classic neurosurgical thinking into saying, maybe this is brachial plexus, because it dramatically increases the reliability. So these are easy cases if you look for them. And it requires a particular type of X-ray, what we call a lordotic AP X-ray, to get a good look at it, and they sometimes get missed. But certainly, if you're seeing an anomalous cervical rib and one of these lower trunk pathologies, you're really going to think of this first. And the challenge comes in the vast majority of cases that don't have a cervical rib anomaly. But this is important to check for, because if you're going to try to fix these, it's not enough to decompress the nerves. You've got to deal with the anomalous rib as well. Now, the categorization of different types of conditions that get called thoracic outlet syndrome is extensive. This is because this refers to both vascular compressions and nerve compressions that occur anywhere literally between an inch out from the spine and the axilla, that whole region. And there are a number of different locations where entrapments can occur along the brachial plexus, the number of locations where vessels can be impinged. There are locations where both vessels and nerves can be impinged. There's no free pass for this part of the body where it's impossible to impinge or entrap the brachial plexus because you weren't taught about it in residency. It can happen, and it does happen. And they're very treatable. Note that with a good neurography, we can have a very good look at the plexus. We can see where it's abnormal, where it's impinged, where it's hyperintense. It's a whole different ball game from the situation decades ago when it was just a black box. And just to run through a collection of possible conditions, vascular impingements that just affect either the subclavian artery or jugular subclavian vein, giving swelling, edema, decreased blood flow. Scalene muscle syndromes, probably the most common type that we'll encounter, where, for instance, whiplash, the neck snaps back and pulls on the scalenes, which run from the cervical spine down to the first rib, and these go into chronic spasm, pinching the nerve elements that pass between them. Proximal fibrous bands, which most commonly will entrap the lower trunk elements, C8 or T1, sometimes in isolation, one or the other, without scalene involvement. First rib entrapment syndromes, not cervical rib, but simply first rib entrapment, because these do happen, and where sometimes the treatment requires a first rib resection. Cervical rib syndromes, always anomalies. Gilead-Sumner hand, puzzling condition, painless hand atrophy, which sometimes is surgically remediable. Distal plexus entrapments. So in the axilla, the axillary nerve, the distal brachial plexus, the axillary nerve itself entrapped, for instance, in the quadrangular space, just medial to the humerus, and along the course of the tendon, the teres minor, teres major, plexitis variants, which are inflammatory conditions, which may mimic entrapments. Post-surgical fibrosis, they've had the surgery and they're recurring. Post-surgical impingements, inadequate decompression. Unrecognized tumors. This is a whole special category here because patients with brachial plexus symptoms uniquely are sometimes operated on without imaging. That is, you have a patient complaining of a complex upper extremity nerve problem. They may even have pain between the neck and the shoulder somewhere. They'll get a spine image, they'll get a shoulder image, and no image of the brachial plexus, and a surgery that not quite indicated, but might be worth a try. Maybe there's a bone spur. Let's do a cervical fusion. And there's a tumor there, and no one ever imaged the area where the pain came from or where the neurology pointed. Another good reason when there's any uncertainty to include these because, again, there is now excellent imaging available through the vast majority of neuroradiology departments around the country that can give you a very good look at the brachial plexus. Now, I want to focus a little more on these proximal thoracic outlet syndromes. Prevalence and perception, it's a very large number. There are hundreds of thousands of surgeries being performed per year for these proximal plexus entrapments, mostly by orthopedic and plastic surgeons, simply because neurosurgeons often never get any training in this in their residencies, which is a problem for neurosurgery. Also, there's a history from the 1980s and 1990s of some of the senior neurosurgeons, the faculty who were taught 30 and 40 years ago that there was no such thing as a thoracic outlet syndrome, completely incorrect in terms of modern diagnostics, but often they'll go on and teach that to the residents. And it's a huge burden for neurosurgery to gradually correct and fix so that we can properly take care of our patients, not miss treatable conditions, and not do spine surgery when there is a brachial plexus entrapment readily identifiable by imaging. Again, presentation, the most classic for these, fourth and fifth digit numbness and pain, negative ulnar nerve studies on EMG, motor symptoms, both thenar and hypothenar eminence, including atrophy, and a variety of shoulder and arm pain patterns, and pain or tonnelles on percussion of the scalene muscles. Here's the anatomy seen close up. you have the upper, middle, and lower trunks passing between the anterior and middle scalene muscle at the first rib, subclavian artery also underneath the anterior scalene and running right over the plexus elements. This is the nexus of a lot of the most common types of thoracic outlet syndrome entrapments. At this point, there are numerous excellent publications, large series, and it is clear that magnetic resonance neurography is effective for the image evaluation of the brachial plexus relative to routine MR imaging. A routine MR is not how you evaluate someone who may have a thoracic outlet syndrome. It's only going to give you a misleading negative study. It just can't show the necessary detail. And there are now a number of comprehensive assessments and publications in this field. And in fact, across, it's one of those remarkable things that in areas of orthopedics, plastic surgery, thoracic surgery, they're doing nerve imaging, and neurosurgeons are not, simply because they weren't adequately trained. And nerve imaging, certainly for the brachial plexus, is something that should be in the range of focus for neurosurgeons, and they should have expertise and knowledge in this area. Now, let's learn a little bit about what you should see. So this is a normal brachial plexus, and what you're seeing here on the patient's left side is a smooth, relaxed course for the brachial plexus elements here. In this case, the C6 and then a C7, and we'll show in other images later how you put these together to see the whole plexus. But with a modern electronic image viewer, you can select a root, and then it will show you the similar root seen in cross section, so you can then track it if you think it's a hyperintensity, match it up, and follow the plexus element. What is MR neurography? Well, it's a collection of specialized image protocols that have selectivity for nerve, just as we have angiography selectivity for vessels. And it's based on the fact that there are a number of unique aspects of nerve relative to MRI. In particular, for instance, this image shows on the right the epineurium. The yellow is interfascicular epineurium, which is a fatty material. The fascicles themselves are inside a blood-nerve barrier privileged space. The green tubes here, which are perineurial linings, and then inside the endoneurial space, where you have the actual axons running in a low-protein fluid in a protected space. And that low-protein fluid is very bright on T2 weighted imaging, but with a long echo time. But when you image a nerve using a standard MRI protocol, what happens is that the signal from the fat is brighter and stronger and more extensive than the image from the fascicles, but much less informative. The result is this. Fat imaging, for instance, in T1 tends to be bright, and the fluid tends to be dark. On T2, it's the opposite with fat sat. Bright endoneurium, bright endoneurial fluid, dark fat. And when you have the voxel size larger than the fascicles, the gray, the bright white and the dark mix, and you just get a grayish mass, and the nerve actually disappears. So only by tuning the MRI to the particular component we're interested in, usually the endoneurial fluid component, and then suppressing the fat using the right size of voxel and orienting the voxel correctly, these are all special aspects of neurography, we can get a great detailed image. And most neuroradiologists these days are being trained in how to do good neurography. And your institution should be able to provide it. If your neuroradiologists are unfamiliar, there are courses at all of the major neuroradiology meetings, and if you give them some encouragement, they can very quickly get up to speed. There are hundreds and hundreds of publications in this field now. And in fact, the unique fascicular pattern of nerve is very helpful for nerve identification. Here, looking at a neurography study of the wrist, seeing the median nerve with that checkerboard pattern, the bright fascicles surrounded by dark in the interfascicular epineurium, which is a fatty substance that's blacked out with a fat sat T2 weighted image here. And once you start to look at nerves, you find some really remarkable things. I mean, here is an image of the carpal tunnel, And you see in image A, the median nerve is ventral in the wrist, with the arcade of the wrist bones above in the image. And in the image below, it's running, the median nerve is between the tendons and the arc of bone. So we see one, it's anterior to the tendons, the other it's posterior to tendons. And interestingly enough, this is the same individual at the same level in the wrist, and he's just moving his wrist back and forth. And that's because the nerve naturally moves within the carpal tunnel. And what you can see when you image with neurography, and it turns out that some patients don't actually have compression of the median nerve when they have carpal tunnel, but they have is restricted movement of the nerve. So when the person extends the wrist, the nerve won't move backwards like it should in the tunnel. This type of adhesive entrapment explains why many patients get symptoms in certain positions with certain activities with regard to nerve impingements, and this is a common issue in thoracic outlet as well. And this is an image of the sciatic nerve showing some of the anatomical basis for the fact that nerves will look bright on MRI when they're irritated. What you're seeing here at the image A1 level is the tibial and peroneal components with the fascicles. At A2, where there's significant irritation and compression, the fascicular component is expanded, so the larger round fascicles, and they're squeezing out the space filled by the fat. The effect overall is to make the nerve look brighter, and this is the basis, the expanded endoneural fluid at the point of irritation. This is the basis for hyperintensity at areas of entrapment and irritation in nerves in MR neurography. And here's an example of how that can work. We have several image slices we'll show you later that capture the different cervical spinal roots. Here, the C6 root on the right side is irritated, so it appears hyperintense. Note that the C7 and C8 roots are distorted mechanically downward by the scalene muscle. Doing good neurography requires good equipment. This patient, for instance, is demonstrating a phased array coil that's actually designed for brachial plexus imaging to get good uniform image signal laterally in an MRI scanner. MRI scanners are often designed to image well just at the center of the scanner, and so we need special coils to get a good lookout distally, and these are widely available now. Phased array coils for brachial plexus, or that are able to capture the brachial plexus. So this is another component, along with special pulse sequences and special image plane orientations, as well as reconstruction and post-processing of the images to see the detail. Here we show another aspect of it, that the actual image planes are not just straight axial, sagittal, coronal, because it becomes important to be able to be parallel to nerves or perpendicular to their course in order to be able to sort out the voxel orientations. This is because the voxels, the three-dimensional pixels, are elongated, and if you have them not oriented coplanar with the nerves, a given voxel is going to report both interfascicular fat and epineurial fluid in the same voxel, and it just turns into a featureless gray and the nerve disappears. So once you do that, this image here shows the kind of fantastic information you can get. We look at A, which is a fairly linear plexus, and the arrow points to just an area of irritation. We look at B below that. Again, focal area of irritation, a little bit more extensive. C, a narrowing of the nerve, increased caliber. D, some more severe hyperintensity with a bend in the nerve, which is small in degree. E, showing an impingement on the top of the plexus. F, showing a more significant impingement from below, such as from a cervical rib. G, notice the plexus is taking a complex S turn. It's pinned down where the arrow points out the scalene, and then it turns up to go over the first rib. and then in H, an even more dramatic complex curvature. So there are absolutely image findings, and if you never image, you have no idea how dramatically the plexus can be impinged in some patients with severe symptoms. When you go ahead and do a cervical spine surgery and they've got a dramatic distortion, which is exactly what happened to this patient who did not get neurography before they first had ineffective spine surgery. This is a reporting of the outcome of the diversity of types of findings you can see. This is from a study of 154 patients with a tentative diagnosis of a brachial plexus entrapment. About 40% were proximal scalene type entrapments, another 23% distal plexus. So between those, you have a major proportion. A number turn up negative, either because they're minor problems or they come up normal, is not a brachial plexus. The occasional unsuspected tumors, plexitis, inflammatory conditions, non-surgical identification of unsuspected severity of a trauma, avulsion injury, or a recurrent, in this one case of entrapment, where there had been a first rib resection and the proximal stump of the resected rib was pushing up into the plexus, causing additional trouble. For a scalene syndrome, some typical findings. Clinically, fourth and fifth digit pain, symptoms aggravated by elevating the arm, absence maneuver, so you're checking the pulse at the radial artery, and then you have the patient look to the opposite side and bring the arm up overhead and see if the pulse drops out. And what this maneuver is doing is it's pulling the scalene tight against the subclavian artery and cutting down pressure out to the hand. You also have the Roos maneuver, where you have the patient with their hand up and open and close their hand rapidly and see if they tire rapidly from vascular insufficiency. Distal EMG or NCV may be negative. EMG and NCV have a difficult time diagnosing the deep neck abnormalities like this. Tennelles or tenderness over the scalene, and there may or may not be numbness or weakness, that is pain only in the more mild cases. And you will see in the image distortion of the involved plexus elements and some hyperintensity, distortion of their course. In a more severe syndrome, you're going to see the hand atrophy, and with regard to the both typical thenar and hypothenar eminence, more severe mechanical distortion, more severe extensive hypertrophy, as seen in this image. Here's more of a close-up look at one of these more severe cases with fairly remarkable hyperintensity in a focal location suggestive of mechanical impingement. But here, rather than a scalene syndrome, we're out a little further, and this is a compression between the clavicle and first rib, so there's less mechanical distortion, but can be very significant hyperintensity change. So here is an example of how imaging can also reveal the vascular impingements. Here on the left, you see the subclavian artery curving across the area of the scalene muscle, whereas in the patient seen here on the frame on the left side of the image, that the subclavian artery comes out. It is disappearing behind this interscalene muscle, then reappearing, and this can be seen nicely in cross-section as well in those patients that have some subclavian artery impingement along with the nerve impingement from the scalene syndrome. Here's another example of why imaging is helpful. This patient has a diffuse plexitis. Notice that there's a remarkable degree of hyperintensity. The nerves are not swollen and they're not distorted in their course. So this is an inflammatory condition. One possibility is an autoimmune neuritis. Treatment may involve medications like Singulair, cyclosporin, and even Enbrel or Humira, as these can be TNF or tumor necrosis factor mediated autoimmune neuritis conditions. Gilead Sumner hand, so painless hand atrophy. Some of these are kind of neuritis or neuropathy, but some have mechanical distortion, and you can get recovery of hand function with decompression. So something that you may still want to consider even in the situation of the painless hand atrophy. You can also see other nerves involved here, the long thoracic nerve, which will give a serratus anterior weakness so that the scapula won't rotate. You get scapular winging and difficulty lifting the arm overhead because the person's unable to rotate their scapula to point the scapulohumeral joint upward, which is really required in order to get your arm fully elevated overhead. And this is a condition that dominated by upper trunk impingement, which will be shoulder pain, often confused with a rotator cuff, but an absolutely normal looking shoulder joint on imaging. Nothing for the orthopedist to do endoscopically there, no pain to palpation, but maybe a deltoid weakness, unable to lift the arm to 90 degrees. Here's an example of really proving how what the image is showing is indeed the relevant pathology. We're seeing in the top left a distortion in the C8 spinal nerve, indicated by the asterisk and the two arrows, and an image showing how the pathology looks, a drawing, and then a post-op image below with that kink gone, the contralateral side, and the patient did experience complete relief of the pain and atrophy, pain and weakness affecting the right hand here. Another comparison of different sets of findings. In A, normal plexus, smooth linear course. B, downward deviation, impingement. C, a fibrous band entrapment proximally with more significant hyperintensity affecting primarily the C8 T1 spinal nerve, and then C2, both an downward impingement affecting the proximal root and then an upward impingement around the proximal rib. Another case showing the fairly dramatic distortion of the plexus elements across a really tight scalene impingement. A patient with a right and left comparison, focal impingement at the area of the scalene muscle with an upward deviation at the first rib versus a smooth course of the plexus through both of these areas on the uninvolved contralateral side. Here, a patient with reflex sympathetic dystrophy or complex regional pain syndrome because of very severe entrapment. You can see the complex course and kinking of the brachial plexus, fairly dramatic, and the subclavian artery being part of the impingement here because of the degree of angulation of the plexus. And then the same patient after surgery had excellent relief of symptoms, and you can see how the entrapment actually and distortion of the plexus is relieved by surgery in correlation with the relief of symptoms. And then another type of image finding is an asymmetry of the anterior scalene muscles. There could be hypertrophy on one side from muscle spasm. There could be atrophy, but asymmetry is somewhat correlated, but really should be done together with neurography to get a full idea of the essence of the pathology. Now, in a scalene syndrome, another good diagnostic maneuver is a scalene muscle injection. These really need to be image guided. We take for granted that for spine injections, you can see the needle and you can see the vertebra, so you know where you're going, but here you're injecting a muscle, and it is something that many pain specialists are just not that experienced with. So yes, ultrasound may be helpful, but it gets very puzzling. You know, you have the carotid, the jugular, you have the stellate ganglion, you have the brachial plexus. It's a fairly dense area to be working blindly in with the needle. So MRI guided injections are very helpful. Anterior scalene is often done by pain specialists, so more and more are experienced with it, but very often you have to treat the middle scalene as well to expect to get a good result. And these are both diagnostic and therapeutic. Here we see the injectate darkening the anterior scalene muscle in a focal area, and because of fibrosis or scarring, the injectate doesn't spread fully in the muscle, and you would need to put in hyaluronidase enzyme like Hylenex to break down the scar tissue and get a adequate or complete relief. This shows a more extensive procedure where the needle goes in first into the anterior scalene. The anterior scalene turns dark as it's injected in B. In C, now the needle is directed to the posterior aspect of the middle scalene, and then now in D, the middle scalene and the anterior scalene are turned dark by the injectate in this type of image sequence. Here we see injection treatment for the distal plexus. This is an example of image findings for entrapment at the level of the first rib. So it's a little further out than the location you look for a scalene, and a lot of different pattern of entrapment. Here again, comparing the location of the scalene impingement at 5 centimeters out from this midline of the spine versus a first rib entrapment, deviation upward with a distortion of the course of the plexus centered at a point a good bit further out. And then cross-sectional imaging, nerve cross-sectional imaging through the area also helps more clearly distinguish them, as well as physical exam. So when you're suspecting a cervical rib, you have to get the AP lordotic X-ray. MRI is very difficult to read for this. Here is a patient who's had the first rib resection on the right, but there is a cervical rib which was not resected, which continues to be a problem on the affected side. And this is a specialized additional problem of the cervical rib contacting the first rib, C7 rib contacting the first rib, and there being some hyperostosis associated with this rib-to-rib contact, wherein that hyperostosis is what is actually impinging and distorting into the nerve element. Again, neurography shows nicely what has to be done to get this relieved at surgery. Here is another image showing a costoclavicular impingement. And this again is a person with a narrow space between clavicle and first rib, so you can have an impingement in that space, narrow costoclavicular angle. And here is a patient who's had a transaxillary first rib resection, but the proximal rib segment was left in place and has swung upward into the plexus, so that they had a first rib resection, but were made worse by it because instead of decompressing the plexus, it let the rib remnant shift upwards into the plexus, making the condition worse. This is an image of an axillary nerve entrapment showing the axillary nerve impinged at the quadrangular space, which can give pain in the deltoid and weakness for arm elevation, abduction. And this can be identified by physical exam by palpating in the posterior axilla for a nerve quality pain. Here's another type of problem that can occur after a first rib resection would be extensive fibrosis. We recommend placing adhesiolytic agents after both scalene and first rib surgery to prevent adhesion. Notice that the plexus elements have lost their separate definition because they're adherent to each other in the area of fibrosis. Now, the surgical exposure is done through a small incision in the low neck and a skin fold, starting about a centimeter lateral to midline, running parallel to but superior to the clavicle. You want to be high enough above the clavicle so that the incision is not stretched over the clavicle post-operatively to get the best cosmetic result. Notice that the patient has been positioned with their arm in a plastic fluorodrape so that hand can be observed as nerves are stimulated to be able to fully clarify what hand movements are being precipitated and to better identify what's being stimulated. Also, extensive electrodiagnostic monitoring. Here, electrodes, biceps, triceps, pectoralis, serratus anterior, deltoids, forearm musculature, hypothenar, thenar, really very good coverage so that you can use a stimulator to locate the nerve elements when they're difficult to see well. and then an image following the scalenectomy. You see the subclavian artery has been decompressed. The scalene is right up against it, has to be carefully protected. Some surgeons advocate having cell saver in the room in case you should injure the subclavian artery, but very careful attention to this can avoid that complication. You see now with the scalene muscle removed, you see the phrenic nerve running vertically through the area, and you always have to take great care not to injure the phrenic nerve. So you're approaching, you do your skin incision, you make a space between the elements of the sternocleidomastoid without necessarily cutting it at all. No need to cut that. Elevate the omohyoid superiorly, move the jugular medially, and explore through the scalene fat pad with stimulation to locate the phrenic nerve, protect and move the phrenic nerve, identify the subclavian artery, protect it, secure the anterior scalene, pass a tie around it, elevate it, and carefully resect the anterior scalene both distally, proximally to fully remove it, and to decompress the subclavian artery and the lower trunk of the brachial plexus. The middle trunk of the brachial plexus will be involved as well. And to the extent the patient has upper trunk involvement, that needs to be cleared up as well. And you may need to take some of the middle scalene, usually, and take a little bit of the middle scalene because you don't want to leave the area unsupported completely. And you can get a very nice decompression. You put in your anti-scarring material, your adhesiolytic such as Ceprafilm, and then pull the fat pad back across over the nerve, securing it with some stitches onto the jugular fascia. Let the sternocleidomastoids fall back together, close the platysma to get the best cosmetic effect, a nice subcuticular closure for the skin. Where there's distal plexus entrapment, you should make a second incision, and we see here the arm is then swung out laterally during surgery, still in the bag for stimulation, and the surgeon then comes below the arm. We use an overhead retractor to elevate the plexus, and you have very good access from the axilla all the way approximately to where you can reach from the supraclavicular incisions. You can get a complete decompression from these two small incisions. And this is not for first rib resection, but this is for distal plexus neuroplasty. And here's the closure, small 2.5 centimeter incision in a skin line. You see the midline of the clavicle marked, and you can get a very nice result with this. You want to avoid the postoperative problems with fibrosis in the proximal or mid-plexus, as discussed earlier, by placing the Ceprafilm adhesiolytic. And again, reviewing the details, incision above the clavicle, just spread between the sternal and clavicular heads of sternocleidomastoid, retract the scalene fat pad, mobilize, carefully protect the phrenic nerve, carry out your neuroplasty, upper trunk, middle trunk, lower trunk, suprascapular nerve, accessory nerve, resect the scalene segment, and then the neuroplasty for middle and lower trunks, releasing the subclavian artery, partial resection of middle scalene as needed, and at the end, reattach the scalene fat pad to the internal jugular vein fascia, and then a transaxillary approach if needed, a small incision high in the axilla, elevate the pectoralis muscles, and you can do your neuroplasty of the axillary nerve and the various plexus elements as needed. The adhesiolytic agents are very important. They make a huge difference. They reduce your risk of adhesion to really just a few percent, or in some studies, even less than 1%, where there are studies without adhesiolytics can have recurrent adhesions as high as 40%. So with Ceprafilm, which is used, for instance, by the gynecological surgeons, if they do a laparotomy, want to come back and do a laparoscopy, they'll put this in there. We take the Ceprafilm, cut it up in small pieces, and put plenty of this in and around the nerve elements, and you get a very nice adhesiolytic plane. Your outcomes with a bit of experience should be good. These patients do well. They get a nice relief. They don't recur. You just need to be thorough. Use the adhesiolytics. and do the appropriate surgery, whether it's an anterior scalene resection, a transaxillary neurolysis, or refer out to a thoracic outlet surgeon to do a first rib if the first rib is exactly what's needed and the scalene and distal neuroplasty are not going to be sufficient. In this group of patients, we had an overall 85 excellent to good outcome at 2 months, which fell off somewhat at 6 months, but beyond that point, these patients maintained their improvements, very few recurrences, and even resolution of some CRPS patients with this type of surgery. In the event of recurrence, you may be able to go back and inject hyaluronidase or reoperate and be able to improve those. Other types of major complications that were avoided were any vascular neurologic injuries, no chyle leaks, as you have to be attentive to the thoracic duct, and very gradually making your progress to expose the anterior scalene muscle. Pneumothorax is possible, but if it's a small puncture and you detect it, and you should always check at the end of surgery, put some fluid, have a Valsalva maneuver, put some irrigation fluid in the wound, have the anesthesiologist do a Valsalva maneuver, see if any bubbles are coming out. You should be able to protect it adequately with the closure, and if it's you do a post-operative upright chest X-ray, if the symptoms are present or if the pneumothorax won't resolve, you can put in a small Heimlich valve and it should resolve overnight. And it's possible to do these very nicely with a very low risk of infection as well. So in summary, you have to be aware of the diagnosis, how to quickly include the necessary steps in a physical exam if there's any suspicion of this, have your neuroradiology staff able to offer a good neurography study, learn to review it yourself, understand the special aspects of imaging required to get a good look, and then get familiarity with the surgical technique, and you'll be able to do the right surgery by offering a thoracic outlet nerve decompression, or refer out to a subspecialist if that's your preference, or include these patients in with your spine practice to add another area of expertise to your ability to treat peripheral pain, weakness, and disability, distinguish the nerve from the spine, and treat each as indicated by the best diagnostics. Thanks.